we go on to the next speaker, Dr. Ashok Grover, who's going to unravel the mystery of watery eyes. Dr. Santosh, stay on with us. Preferred practice guidelines in a congenital nasolacrimal duct obstruction.
So unraveling the mystery of watery eyes in 5 minutes. The watery eyes in early infancy may represent congenital glaucoma, which should be excluded, but the lacrimal outflow difficulties, most common being nasolacrimal duct obstruction, are the more common cause. The nasolacrimal duct has a large osseous part and a small 5 millimeter membranous part. The obstruction most commonly is at the blockage at the valve of Hasner, which is the lower end of the membranous part where it opens into the nose. But there are several other abnormal ways in which the opening can end. The clinical presentation as epiphora, discharge and matting, unilateral or bilateral, is the common one. Regurgitation on pressure is the commonest sign, but acute presentations can also occur. The natural history is that 95% present with epiphora in the first month and 96% have an overall spontaneous resolution in the first year. Conservative management comprising the appropriate way of hydrostatic massage over the sac or a minimally invasive technique like probing and surgery, which is the Dacryocystorhinostomy, constitute the mainstay of. It is important to massage well and explain it well to the parents. The probing and syringing is done if the watering persists. It can either be done early or at about 9 to 12 months or later. The consensus is on its use at about 12 months or later. The probing technique will not be detailed here because of paucity of time, but one needs to guard against false passages and the difficulties in complicated NLD obstructions. Success rates can be very high, up to 90%. Failure only because of improper technique, or recurrence of obstruction, or anatomical variations. The success is less if you do it late, more than 36 months of age, or in complex NLD. Failed probing can be tackled by repeat probing if it has been done outside and you haven't done it earlier, or an inferior turbinate infracture, or balloon catheter dilatation, silicone intubation. Endoscopy has proved to be a useful tool, and where all other measures fail, by Dacryocystorhinostomy. Inferior turbinate infracture has proved to be a very useful technique in my hand. It works in most of the cases of failed probing. Balloon catheter dilatation using specially designed balloon for the purpose is a very useful tool, but limited by the cost, and the results are virtually the same as they are for silicone intubation, which may be a less costly option. The success results with silicone intubation, primarily done in failed cases, is a useful technique also in complex obstructions. Nasal endoscopy has added a new dimension, especially for complex NLDO, failed probing, nasal cysts, or other associated pathology, and probing success rates improve with this. Let's look at the endoscopic visualization and its role in those cases which are complex. So we are seeing the inferior turbinate, we can see the inferior meatus, and when we pass the probe, we can normally see the probe coming in. Here we only see it denting the mucosa. And in such a situation, you can, if you're working under nasal endoscopic control, use a sickle knife as we are doing here to get an opening and get the mucosa to be opened up so that the probing can be successful. So this is where we can now see that the probe has now reached the nose. Dacryocystorhinostomy is indicated in cases where the obstruction persists in spite of all the procedures that we've spoken about. External and endoscopic have both been advocated, but external is the more common standard approach for children. There are certain technical difficulties in Dacryocystorhinostomy in children. but the results are still very good. So congenital nasolacrimal duct obstruction is a fairly common condition. Almost up to 3 to 4% of children will have it, but currently available techniques offer a very high rate of success. Newer techniques, especially endoscopic visualization and endoscopy guided probing, have contributed to greater understanding and better success rates in congenital NLDO. Thank you.
Thank you very much, doctor. Is there a particular situation wherein you will not be conservative and wait for probing, but think of doing it earlier?
Well, one very important reason is when the parents are overtly concerned and they're very anxious. Then you may opt to do it early at the age of a few months. Then, of course, there are those conditions, medical conditions, where you may be forced to do it early. One of them is if there are recurrent attacks, which are relatively less common in children. And a very unusual one is a congenital Dacryocystorhinostomy, where there may be unilateral or bilateral non-compressible sac swellings on both the sides. They need to be probed because, one, you don't want that kind of a swelling to remain, and number two, some of them are associated with cysts in the nose, which may have a bearing on the breathing of the child.
Thank you.